Continued care, evolving roles of enabling services staff in diabetes management. We will get started in just a minute. We'll give people a second to get logged on and settled. All right. I think that we will get started. We have a tight timeline today, and we have a special guest speaker from San Ysidro Health. So I will start to get us going. Like I said, I'm Cindy Selmy. I'm the Executive Director of Health Outreach Partners. We are part of the Diabetes and Special Vulnerable Populations Task Force, and welcome. Next slide, please. Our learning collaborative today is about enabling services staff. And as we know, diabetes affects more than 34 million people in the United States. And our task force looks to improve health outcomes for diabetes patients in our most vulnerable populations. We are a member of 14 national training and technical assistance partner organizations funded by HRSA to address diabetes care in health centers across the nation. Our learning collaborative is sponsored by HRSA and will take a deep dive into the issues related to the roles of enabling services staff, developing patient-centered resources, and improving care, health equity, and management during a disaster in diabetes care and management. We do have a website, the Diabetes Task Force. Please visit chcdiabetes.org. Next slide. These are the 14 national training and technical assistance partners that are members of the task force. We span across the country and represent many different areas of healthcare. Next slide. Our learning collaborative that we have for the next 4 sessions is being sponsored by APCHO, Health Outreach Partners, MHP Salud, and NOAA, the National Network of Oral Health Access. Our faculty who will be facilitating and hosting the next 4 weeks are Albert Eisen Jr., Associate Director of Training and Technical Assistance from the Association of Asian Pacific Community Health Organizations, myself, Hansel Ibarra, Program Director from MHP Salud, and Dr. Irene Hilton from NOAA. Next slide. This is our 4 sessions with the dates and times as we are starting today, and then we will have session 2 on February 2nd, session 3 on February 9th, and we will wrap up on session 4 February 16th. All the times will be 11 a.m. Pacific and 2 p.m. Eastern. Next slide. The Diabetes Task Force is excited to have our website, and again, our trainings and our learning collaboratives are noted on our website, so please visit our website. All right, so for today, we have 2 learning objectives. First, we are going to end today hoping that we understand the role and responsibilities of enabling services staff and how the social determinants of health impacts diabetes management for special and vulnerable populations. We also Can we go back one? Thank you. We also want to be able to use social determinants of health and enabling services data to address health equity and the relationship to quality and population health management for special and vulnerable populations. Next slide. The last of our housekeeping is we are on a Zoom meeting and we will be having a breakout session. So at that time, you will be invited to go to the left-hand corner of your screen and unmute yourself and to be on camera to chat with your colleagues. Please, if you have any questions, you can put them in the chat. One of our team is going to monitor the chat. And we will have a question and answer session at the end of our presentation, as well as our breakout sessions. A brief word about our agenda. We are going to have a presentation for the first 20 minutes or so, and then we will have our breakout session followed up by a debrief and a question and answer. Lastly, we will have a short survey at the end, and we ask that you all fill that out before leaving. We are offering CMEs today, and we ask that you will complete the survey at the end of each session, as well as the evaluation after the completion of this learning collaborative. And the CME and CNE units will be offered from Migrant Clinicians Network, and you can contact Martha at the email on the slide for questions. Next. All right, we want to just take a minute to do an icebreaker and find out who is with us today. We thank you all for joining us. So if y'all could take a minute and put your name, your title and role, and the name of your organization in the chat. And also include, if you will, what accomplishments you are most proud of from 2021. I can only speak for myself. 2021 was a hard year, and it's nice to take just a brief minute to reflect on the good parts, because I do think there were good parts. I do think a good accomplishment is we made it through. But professionally, I'm going to say my proudest accomplishment was working with this team, and that we put together a really good program at the end of the year with our national audience series. All right. I'm going to move us on while we do that. We introduce ourselves. Welcome, everyone. All right. So what are enabling services, and who are our enabling services team members in our health centers? There are many categories of enabling services, and they all have a very specific role in supporting chronic disease and diabetes management in our health centers. We have social services, assessment, counseling, interpretation staff. We have individual health education, group health education, outreach, in-reach. We have our transportation services, financial counseling and eligibility, referrals, case management, and all of these roles in our health center support the clinical team in being able to provide whole person care to our diabetes patients. Next slide. And these services are important for many reasons. Like I said previously, they support the whole person and not just the medical manifestations of chronic disease. They also work to improve access to quality care. Patients are able to have a reliable way of reaching the health center. They're able to communicate with the staff in their own languages, and it just overall improves their experience. It addresses the social determinants of health that, as we continue to learn, play a big role in illness and or wellness, depending on our patient population. The enabling services team, and when we collect data and go back and look at that data, we are able to see that health outcomes in our communities and for our patients are greatly improved when we utilize our enabling services staff. And it helps us to achieve the quadruple aim, which is a framework in healthcare to optimize healthcare. Next slide. The quadruple aim is based on improving population health, which is the health outcomes for our communities and our patients, reducing the cost of care, enhancing the patient experience, and also improving provider satisfaction, therefore reducing burnout and reducing turnover and being able to have continuous quality care for our patients. Next slide. And this conversation would not be relevant unless we acknowledge and review the social and economic factors that drive the health outcomes, particularly for our under-resourced patients and our under-resourced communities. Many of our communities that our health centers serve are patients, they don't have economic stability. They have, they're underemployed, their income, they are low income, they have housing struggles, they don't have safe housing, there is no transportation or unreliable transportation. Education and health literacy and literacy in general are scarce or under-resourced. They experience food insecurity, and they, particularly we are seeing in this time of COVID, are experiencing social isolation, and the healthcare systems currently are very stressed. They are not able to access healthcare. Healthcare providers are leaving their jobs, and it is very hard to be able to reach and receive care. Particularly what COVID has shined a bright light on the fractures in the healthcare infrastructure that we are experiencing on our health centers. So given that, the next slide, I am really happy to introduce our guest today, Sonia Tucker. She's the Vice President of Population Health from San Ysidro Health Center in San Diego, California. Sonia, she is a trained physician, trained overseas in Venezuela, and she is responsible for overseeing the population health of her organization, which entails quality of care, risk management, patient access and experience, and lastly, the social services department. She moved to the United States, where she has worked with nonprofit organizations, traveling worldwide to provide high quality primary care services to people who can't afford them. She obtained a master's in business administration with an emphasis in healthcare management. And Sonia has spent most of her career educating patients about the importance of preventive medicine, the advantages of public health, and creating systems to ensure the quality of care. She's been working for FQHC health centers over a decade, and her work has led to improvement in healthcare organizations she has worked for. During her work at San Ysidro Health, Sonia and her quality team guided the transformation of 7 medical practices. The transformation took place during the pandemic, and San Ysidro Health accomplished national quality recognition despite the barriers to care that the pandemic had placed on the medical care system. And she's going to share with us today her work at San Ysidro Health, and I'd like to welcome Sonia.
Thank you, Cynthia, and it's a pleasure talking to all of you guys. So, Cynthia, I really liked the the presentation that you just gave, just because I think what we are going to try to do here is to really put together what you did, what you just said, into how do we really do this in the clinical setting, which is kind of, it is sometimes can be a little bit abstract, and people can think, okay, my gosh, this needs a lot of resources. So allow me to kind of tell you what it is that I'm doing here at San Isidro, and kind of a little bit of what I've done in the past in other community health center. Next one, please. Perfect. So before I go further, I wanted to kind of tell you guys a little bit about who we are in San Isidro. So that way you guys can see that this is something that can be scalable, that we're able to provide the information that I'm providing to you guys. You'll be able to take it and really scale it to your needs. So San Isidro Health started as a small community health center over 50 years ago. In San Diego County, we are about a mile away from the border. So that adds an extra layer of complexity, because we have a lot, what we're calling transient patients, when in reality, they're not transient patients, but we have binational healthcare programs here, because we have patients that go across the border, Mexico into United States. So those are areas that we have to take into account as part of social determinants of health that not necessarily everybody has if you're not in a border town. So with that being said, San Isidro Health has been growing in the past, honestly, in the past 3 years, the growth has been immense. It has been very important. We have can we mute the stuff? I have a hard time with the background noise, sorry.
Yes.
Perfect, thank you. So San Isidro Health has been able to accommodate and just move with pandemic as well as the growth. So within the past 2.5 years or 3 years, we absorbed another community health center, which allow us to give access to care to patients in the rural area, which was something that we hadn't done before. And we have been also working with other smaller practices we have been incorporated into our clinic. So we are now a community health center with more than 20 sites. We have, I believe at this point, we have 24 sites that give, this is only the medical sites, but what I'm about to tell you guys, this can be done at a smaller community health center. It can be done in one particular site. It can be done in a different way. So it's something that can be scalable. Next one, please. So that basically, and I do apologize, I noticed that I had a little, when I sent the PowerPoint, I noticed there was something that it was a little bit of a glitch right there with that S. So what we are talking here, and this is, interesting enough, we have been working on, I've been working with social determinants of health for over 10 years, before social determinants of health was a buzzword. So to me, what's important is to understand that, and I think for our providers as well, is to understand that quadruple aim. And I love, Cynthia, that you're saying quadruple aim, because what we're also really utilizing is the selling point for our medical team is we don't want to add any more to them. What we want to do is we want to provide that extra help that our clinical team needs in order for them to be able to work from their maximum potential. So, and that's exactly what we have tried to accomplish with this. So the first one, so we're talking about diabetes care management and support, but we also have done something very similar with other quality metrics like colorectal cancer screening as well as hypertension. Next one, please. So basically the goal was San Isidro wanted to establish a comprehensive diabetes care program. And if there are other people here in the audience that are coming from a federal qualified health center, you know that HRSA is really putting a lot of emphasis on this. HRSA is really making sure that we're able to address that, because we noticed that as providers, the clinical team has prescribed all the medications. We have newer medications, but in reality, those medications are only so much effective if we don't address the bottom line is, do we have food insecurities? Do we have patients that are homeless? How do we have transportation issues? How can they access care, et cetera, et cetera, et cetera. So the program was to leverage enabling services to prevent and reduce the complications associated with diabetes that usually we don't see immediately, but we will be able to see those complications down the line. And the whole idea was to have an alignment a multidisciplinary team approach to integrate that into a patient-centered model. Okay, so what we've done is, to improve access and engagement to these comprehensive health services for diabetic patients, and really utilize all the people, and I think Cynthia said it, it's, by the way, just for the record, Cynthia and I did not necessarily talk about what she was going to present, and I was like, oh my gosh, this is perfect. Because this is the idea, is to really utilize the staff that will be able to teach your patients how to self-manage and how to self-coordinate them, with their help, to be able to allow the providers to work from their maximum potential. So we are utilizing a population health approach because, of course, we have tons of diabetic patients because we're big, but we need to figure out, okay, what areas of the population are really a lot more at risk. And now at this point, as we speak, we're breaking it down according to race, ethnicity, as well as other social determinants of health that will allow us to really tailor this very comprehensive approach according to the needs that they have. We are aligning all this information with the ones that come from community health centers or that have Medicaid or Medi-Cal payers. You know that HEDIS is something that we live and breathe every day. So we're aligning that with HEDIS, as well as for us, that we are patient-centered medical home model with our patient-centered medical home and quality metrics. And finally, we're really proud of utilizing our enabling services staff to whatever that they are doing, that's what's the best that they can do. So in reality, we know that doctors, and by the way, I love my doctors and providers are great at everything what they do, but they don't necessarily have the time to educate our patients. That's why we have health educators. They don't have the time, the MAs don't have the time to really navigate for our patients. So that's why we have patient navigators, care managers, care coordinators, et cetera, that can do something for that diabetic patients to be able to be in control. Next one, please. So I wanted to be transparent and kind of show you guys. So we look at not only how many diabetic patients we have, we looked at them per site. And in fact, this is our December 2021 hemoglobin A1C testing, which, by the way, I was very concerned because I feel like we should be able to get to this point. And that is what allow us to really put this plan in place, because we want to be to 90% of compliance rate on diabetes testing. Next one, please. So this is our goal, and this is how we have been doing it. By the way, as you guys can see, we have a big dip down, and then when we started implementing this approach, we started seeing a little bit of an increase. So our goal is to be down to the MPL, which is something that we have established ourselves. But at the same time, as we are increasing access to care and we are utilizing social determinants of health as part of what we're doing, we are also hoping to see that the patients that get hemoglobin A1C testing are also being able to be in compliance, or that to decrease the non-compliance rate. So even though we look pretty good, so as we are increasing the number of patients that are getting hemoglobin A1C, we have to also make sure that they are in compliance, and whenever they get the hemoglobin A1C testing. So that is a double whammy right there. Next one, please. So this is the total patient population. So as you guys can see, we're not only focusing on diabetes, but also on pre-diabetes, because the doctors on the phone, they know that your pre-diabetic patient, if we don't do something about their education, if we don't change their habits, if there's not a lifestyle change in dietary modifications, those patients are going to end up being diabetic sooner rather than later. Next one, please. So basically, this is how it is that we have the structure, and we have different regions in San Diego County. So we are west, south, and center. So what we're doing is really utilizing our groups, which we're going to go through that depending on the regions where they are. Who is involved in this workflow, in the referral? So which I was very glad to see that Cynthia was also, talking about referrals and case managers. So here it is. And also we have already programs in place that we need to make sure that we align them with all the social services that we have. So ECN for the ones in California is Enhanced Case Management, which before it was called HHP, Health Homes. We're utilizing ECM, we're utilizing chronic care management, we are utilizing diabetes prevention program, which are programs that we already have internally to make sure that we are aligning what we're doing with the medical team. And the medical team is, in fact, one of the areas that we're really working hard is to educate the patients, the providers. You don't have to do this alone. Please allow us to help, which we have been successful at really having the provider just saying, yes, please help me. We need to make sure that these patients are well educated. And I love the fact that we are talking about outreach and enrich staff. So we have staff that do outreach and we have the staff that does enrich. What is the difference? So our enrich staff is the ones that are calling the patients that are already identified internally as patients that have diabetes. And the outreach staff is those patients that are assigned to us because we are PMPM or we have capitation agreements with the health plans to be able to say, hey, welcome to San Isidro, please let us help you. We want to make sure, we want to get to know you and we understand you're diabetic. So those two particular areas are different areas because you need different approaches for those patients. Next one, please. So this is basically kind of an idea of how our program looks like. So our programs, you guys can see on the top, is integration of the diabetes care and enabling services by region. So I broke it down per region. And by the way, something else that we did is we looked at the empowerment per each one of the sites that we work in. So for instance, the Southwest region, we have the ACMO, an Associate Chief Medical Officer, or an appointee, whoever it is. Usually is the CMO in this case because they went to medical school to practice medicine, so they want to be the ones. But if they're too busy, they usually would appoint somebody that will be able to help us at really looking at the different PDSA cycles that we have, because within this, we usually have PDSA cycles going on to see what else can we do differently. Each site has a care coordinator that is assigned to them, and we have about one health educators per 3 or 4 sites, depending on how big the site is. And that would be something that, is a formula that works for us. I don't know if it's a formula that will work for everybody, but we have our health educator director working with them according to the different classes that we have, which we're going to go ahead and see that. And then we also have the projects that I was talking to you guys about it. So the Project Dulce, as well as Project Dulce, is a project that is already part of our program that was there before, but it really takes care of those patients that are really non-controlled and non-diabetic. And then we have also the diabetes prevention program coordinator that both of these coordinators are part of this team. Then we have the social services department, and that social services department with the social determinants of health assessment, which we use the prepared template. And we have our patients. If you guys can see, we have the population health management part, then we have the health support services or enabling services, as well as our medical team. Our medical team or our medical care is by itself there because there are basically, okay, yes, it is very important, but if you guys can see, there's only so much they can do because it's the doctors and the providers as well. They make everything else is the 2 green areas right there, arrows, are those enabling services that we're providing to our clinical team to be able for them to work to its maximum capacity and maximum potential to the top of their licenses. And by the way, this is something that we make sure that we were not overtasking our medical assistant, because those poor girls or guys, also majority of them are girls, are super overtasked, and we want to make sure that we give what they need for them to be able to also have job satisfaction. Next one, please. So this is an idea, this is what we did. That doesn't mean that it's necessarily something that it will work for you guys. And if you guys can see, it goes up and down. The same thing with the previous slide, that can be up and down because the patient can come directly from the provider, or it can come from the patient itself and the social determinants of health team or the social services team. So it is very interactive. So the patients are going to be coming from the different areas, depending on if it's an outreach or an in-reach, or if we are working directly with the provider. So if you guys can see, we're breaking down according to the different levels. So level 1, level 2, level 3. I want you guys to focus on the level 4, because the level 4 is also an area that we really take care of, a lot of the social determinants of health. So we really rely on those enabling services to be able to really bring those level 4, which are the ones with a higher risk, to be able to be compliant. So we relied on our social services department, we relied on our health education team, we relied on our coordination of care team. And if you guys can see, as the patient, and this is up to you guys how you guys are going to stratify this, but as the patient gets more complicated according to your care team, this is important, that it's not going to be the social services, or it's not going to be the care coordinator, the one is going to decide this. This is part of what the provider is working with the enabling services to say, this is what I would like to, and this is work that was done between providers and enabling services team, to be able to say, okay, so this is what we want to accomplish. So also leverage technology. It is important that you leverage technology, because doing the handout of the patient from a services to a services is important that you're able to track it. And if you guys can see, I also put on top of there, the patients that are eligible or already enrolled in enhanced case management or chronic care management program are referred to patient engagement teams. And that's what we're talking about here, is the patient engagement team. However, we do not take those patients out of those programs. What we're doing is we're enhancing the coordination of services that we're doing for the patient at those already really comprehensive programs, to make sure that we have that one-on-one education, or those group of education, and we're not providing it inside of this enhanced case management or chronic care management. We're providing whatever it is we're providing here, but we are complementing everything else according to the structure that I'm showing you guys. Next one, please. So this is just an idea, for instance, a curriculum that we're utilizing for health education and the topics that we're looking into. Keep in mind that when you guys are implementing this kind of education, you always need to make sure that you take into consideration what is the level of education overall of your patient population. So my rule of thumb is always do your readability level at between 3rd and 5th level. Why? Because it's where your patient is going to understand, because you can educate all you want, but if you're utilizing some of those curriculums, and by the way, there's nothing wrong with the curriculums that are out there. Always look at the curriculums that you have, that they are already available, and try to accommodate that curriculum to what you're doing, because there is nobody better than you to know your own patient. So there are a lot of things out there that are really useful, but how do you tailor that to your needs is what's important. Next one, please. And so this is a little bit of what we're doing. And, kind of remember I told you guys that we are aligning the initiatives. So HEDIS, and in fact, I forgot to tell you guys about UDS as well. And for the community health centers that have to complete the UDS, the Uniform Data System report every year. This is something that you guys will be able to see. So we're also wanting to utilize that enabling services, but the overall outcome should be, are we increasing the compliance rate for hemoglobin A1C testing? And when the patient gets tested, are we decreasing those patients that are non-compliant? So basically, and this is kind of aligning all the different departments that work here. So you guys can see there's a place for everybody. We have the quality department with the data and the population health management. We have the coordination of care. Within the coordination of care, we can also talk about other enabling services, but it will be within the coordination of care team, which by the way, are not all clinical people. We train them on what it is that they need to do. And they're the ones that are going to coordinate, okay, so you need health education, you need one-on-one classes, or you need group classes, or you need to go to social determinants of health or the social services because you need transportation, housing, and food. So, and then once we do the handoff, that's when the other departments are coming into play. Then we have the care team. We want the care team to really take care of the patient. They're the only ones that can prescribe the medications. They're the only ones that can tell the patient, you need to make sure that you take your medication correctly. And, let me ask you about your transportation and food. And then lastly, it goes back to quality and coding. Why? Because we want to we want to be recognized for the work that we've done. And the only way that we are going to be able to do that is by really coding the everything that we've done, so that way that can go to the health plans or the federal government or the state, whatever you're sending that data for, and then you can get credit for all the hard work that you're done. Next one, please. And so that is, and I think I don't necessarily, I was told that I only had 10 to 15 minutes, and if I went through too fast of what I was telling you guys, please let me know. I try to cover everything that we're doing. By the way, this is very similar to something that I implemented in the past in my previous community health center, and we were able to decrease the non-compliance rate for patients that with diabetes from 27% down to 15% in 2 years. So that's something that there was a lot of work done, and this is something that you can look at. My recommendation is, if you have, maybe you don't have the 7 case managers or care coordinators, but you have one. So pick your care team that you think it's going to be able to handle this, and have a pilot program, and look at the results that you are getting from that pilot program, and compare it to how it was before. Do a few PDSA cycles, work with your quality team and your data analytics team to see if you're able, what are the differences that you're doing. And I can assure you, when you start looking at transportation, when you start looking at food insecurities, you will see how those hemoglobin A1C are going to come down.
Thank you so much, Sonia. That was really great and such good information. And wow, you guys are doing some great work. I know from our previous conversation that you did say that San Ysidro did use the Prepare for collecting SDOH data. Is that correct? That's great.
That's correct. That's correct. So that's the other part when I was saying, leverage technology. Because when you leverage technology, you're able, and I think all of us have to have EHRs right now. Mm-hmm. So I'm not saying that you have to use Prepare template. That's up to you guys, what you guys use. We use Prepare template. We make sure that when we are collecting that social determinants of health information is documented in structure fields. And those structure fields are they're usually mapped into our population health management tool. And the population health management tool is what we're utilizing to make sure that we are doing the approach to this particular work from the population health management perspective.
Great. While we have Sonia here, let's open it up before we move into our breakout room for questions. Are there any questions? We have one question in the chat from Courtney. When you first started SDOH, did you have any pushback from your patients on why you were asking those things at a doctor's appointment?
You know what, it's interesting that, and this is also part of your workflow. So initially when I started, which by the way wasn't in this organization, but because we belong to the same consortia, we kind of know exactly what it is. So it wasn't so much that why was I asking those questions. It was more of, what are you going to do about it when you find out that we don't have housing? What are you going to do about it when you find out that we have food insecurities? And so it wasn't so much about why are you asking these questions? It was so much about what are going to be the next steps for this. So one area that I usually say when I talk about social determinants of health is, you need to ask the questions that you will be able to address. Because in reality, yes, we all want to collect data, right? Because it will give us information, but you need to be true to yourself and think, okay, what can I do? And you don't have to have all the answers and solutions internally. Your answers and solutions can be by partnering with other community partners to say, how can I address that food insecurities? I don't know where you guys are, but if you here in San Diego County, we have a program that is called 211. So we do a lot of internal and external referrals where we're able to get food and housing and many other transportation to our patients by just doing a referral. So, and we track that in monthly basis and what we do. And that's what we utilize to really categorize the social determinants of health into the complexity of the patient.
Thank you. We do hear a lot in our work from health centers around asking the questions and being able to help them when they do answer them. Albert, are you doing universal SDOH screening for all patients?
So we are doing, initially we were not doing SDOH for everybody, but we recently moved to universal screenings. It is important that we understand according to your needs and the patient population. It is easier, honestly, in my opinion, because I've done both. It is easier to have a universal screening once a year when your patient comes and you have to update demographic information, and you can already you can use that whatever screening protocol that you have for SDOH. Again, if you look at the prepared template, it is a long template that you have to look, okay, what do you have? So you're able, that template is pretty flexible, and you can take and add whatever you think that you want to address within your patient population. So that is how we were able to really use or implement a universal screening, just by, okay, I'm able to address this right here, so this is what I'm going to ask.
Thank you. Other questions from our participants? Okay, well, thank you, Sonia. We really appreciate your time today and your great work that you all are doing at San Ysidro Health. This was very valuable and very relevant to our discussion. So we're very, very grateful.
Whatever I can do to, help, let me know. I think it takes all of us to really bring our patients back to where they should be, and they deserve the best quality care regardless of where they're receiving the care.
Absolutely. Absolutely. Thank you so much.
Thank you very much.
All right. So now we're going to break out into breakout rooms. Going to give our participants an opportunity to get to know one another and to think about this presentation and where you're at in your health center. So I want you guys to think about a couple of questions and share with one another. Does your health center collect SDOH or enabling services data? How are the enabling services staff being utilized in your health center to support diabetes outcomes? And what would you like to change or implement in your health center to better support the care team utilizing enabling services data or staff? So Hansel is going to invite you to join a breakout room. We're going to have about 10 minutes for you to share with one another and then come on back. And please feel free to put your camera on.
How widespread these scams are, or how much money they've stolen?
And I kept the team here on the main group. If you want to, you can go. If you guys want to, we can go into different rooms and see.
Sure. Yeah. I'll go into room 1. And then you'll just yank us back in, right, Hansel? Yes, okay. Cool. Thank you.
Yes, sir. Okay, Irene and Cindy. I mean, you both are here with me, Irene and Cindy. Like I said, if feel free to jump on any of the rooms if you like. If not, we can wait here 5 more minutes.
I went to a room and nobody was in it.
Oh, well, I mean, if you go to room 4,
yeah,
that's the one that I set for us.
Oh, okay.
Yeah, so there's no one there in room 4. There's people in room 3, people in room 2, people in room 1.
Got it. I was so confused. Thank you, Hansel.
Yes, ma'am. I see that Albert joined room 1. I'm gonna go ahead and hop into room 2 just to see if there's anything, any questions, any concerns. So I'll see you ladies in a little bit. I can't hear you, Cindy. What was that?
I said I'll join room 3. Sorry, I was muted.
Okay. Well, I'll see you ladies and we're bringing them back at 1:50, right?
Yes, 5 more minutes. Yes.
Okie dokie.